And what you'll find in this session is some sort of basically revisiting of some of the things we talked about before. But what I will largely want to do is try and talk about what I see as challenges for development of the field, and then sort of where the field's going. So the first few slides are just to remind you implementations of human enterprise that we can study to try and improve our implementation approaches. Implementation science is the scientific study of determinants, process and outcomes of implementation. So relatively new field of health services research. Probably only really got its steam going in the last 10 years or so, maybe 10 or 15 years or so. But that still means it's quite new. It's inherently interdisciplinary. No individual discipline has a monopoly on the skills and the knowledge that's needed to advance the field. And we need a broad range of forms of inquiry. And this was the kind of list of my list of what implementation science covers. Okay, and throughout the last sort of 5 sessions, we've covered off a number of these different areas. So I want to talk about 6 key challenges for advancing implementation science. And so this is kind of whether I'm feeling so the glass is half empty or half full. And depending on the day, I may change my position. So again, we've touched on a lot of these, but I think one of the key issues that we face if we try to, if you like, scientifically address the field is we need to build a shared understanding and language for the core concepts that we're looking at. If we don't do that, then we can't advance science because we can't talk together. So we'll end up with, well, my view of the world is this, and Michael's view is that, tomorrow's view of the world is this, but we never know actually, are we talking about the same thing? In a similar area, I was once involved in some discussions around biomarkers for lung cancer, and you had lots of people who discovered a biomarker on a relatively small data set, and they never actually shared, so you never knew whether they all discovered the same thing, or whether they discovered different things. And partly because it's very commercially sensitive, because if you get the biomarker, then you become the billionaire. But it was a problem with the science, and the science didn't advance because you never had enough knowledge to sort of say this biomarker is useful. So I think we really need to try and address that. I think I showed you this slide on the first session, which is just demonstrating that even at the level of defining the field, there's no consensus. This was a study where we asked 30 different funders in 8 countries, do they have some responsibility for knowledge translation implementation? They all said yes, and they had 31 different terms. So my sense of this is that we don't worry about what it's called. We actually just sort of try and make sense of what the science tells us for trying to improve implementation. One of the other challenges is, particularly in this area, that we seem to love creating new terms and new sort of calling or developing innovations and giving them new names. So this was, again, I think I've shown you this, a nice paper by Kieran Walsh, who just looked at how the language in quality improvement had been evolved over a 20-odd year period. So he just did a Medline search and looked for different terms for audience feedback, and you can see that in the early 1990s, everyone was talking about medical audit. Then it became, where did that one go to? TQM. Then it became clinical governance, and now people are talking about Lean and Six Sigma. And one of Kieran's comments was actually, there are probably more things that are common across these approaches than different. But if we constantly reapproach or constantly reinvent the wheel, you call it a process of pseudo-innovation, it actually has disbenefits. The QI programs need sustained long-term investment and support in order to bring about significant improvements. And the repeated redesign of QI programs may have damaged or limited their effectiveness in many healthcare organizations. So we shouldn't get hung up on language, and we should be very cautious about this pseudo-innovation, because when people do that, they tend then to sort of think that everything that's been discovered before isn't relevant to us, when it should be. So one of the things that we've been trying to do is see whether we can get various groups who are working on this together to talk about it. So in a grant that we had, we proposed developing a wiki and trying to get people to talk, to sort of, basically jointly create a taxonomy for implementation strategies. But for various reasons that got delayed in starting, and while we was delayed, we identified about 8 other groups around the world doing something similar. So instead of doing our wiki, we got a meeting where we got the other 8 groups around the world. So Jennifer Lehman is someone working in public health. Susan Leakey, we talked about a lot in psychology. Peter Bragg is based in Australia, there's a lot of taxonomy, particularly around neurotrauma. Suzanne Hempel's from RAND, and she's been working on trying to define quality improvement interventions. GJ was from the Netherlands and worked on implementation mapping. So it was, rather than sort of saying we're going to create a 10th language, the idea was can we get people to come together to at least have a conversation, see whether it's worthwhile trying to develop a joint view. We had a different model that you might end up with different languages and just say, okay, public health, we're going to use this tool. We might be able to get a Rosetta Stone. So, okay, in public health, you call it this. In implementation research, we call it this. And as long as we know where they're at, that's going to be at least helpful. Or we might get to a unified language. And it seems unlikely we get to a unified language just because there's been such an investment in sort of these different areas. But we might be able to get to that shared understanding about how concepts work across each other. So too many theories, not enough theory. We have a profusion of theories that are often poorly conceptualized, rarely operationalized, and even more rarely tested. What I want from a theory is a kind of summary of knowledge that will allow me that when I use a theory to develop an intervention, that the intervention is going to be more successful than if I was using my common sense. Okay, that's what you want, an incremental improvement. We don't need theories that explain everything in the universe. All right? What we do is just need theories that will help us go from maybe a 10% improvement to a 15% improvement in a fairly consistent way. And if we've got that, it's helpful. Most of our thinking in science is incremental. There's often not very good sort of evaluation of candidate theories and not very good development of interventions to test theories, which was kind of what we talked about when we talked about the behavioural approaches. And if I'm talking to a social science audience, I occasionally say, should there be a balanced theory developed until we've tested the currently available theories? And they often aren't very happy about that. But there's a danger that we do a lot of theory generation and not really then test it. Ian Graham, when he developed the knowledge to action framework, identified, I think, 33 planning frameworks from different sectors, but there were a surprising number that had a single author that were published and were never cited. Doesn't sound like that's sort of a contribution to science. It sounds like it's almost a personal sort of project. And where might we get to? Well, we may find our theories work, we may find they don't work, both of which are useful. This is a very lovely challenge by Robert West about the trans-theoretical model. So for Chaska and DiClemente, which is a stage-based model, the idea that as we change behaviours, we go through a series of discrete stages, from pre-contemplation to contemplation to planning to action to maintenance. Okay, thank you. And in 2005, Robert wrote this paper that basically said there are serious problems with the model. But its popularity continues largely unabated. This editorial does not seek to revisit all the evidence from such analysis and raised against the model. It simply argues that the problems with the model are so serious, it's held back advances in the field of health promotion, and despite its intuitive appeal, it should be abandoned. It should be discarded. Now is the time for change. Let me see. Okay, so that's largely what I've done. He says a replacement is needed that more accurately reflects observations about behaviour change. Well, if you look at the empirical evidence, first of all, these discrete state changes are often not defined in discrete changes, they often overlap. and also the experience that people will go from, say, pre-contemplative to just doing it. So some people jump from stage 1 to stage 4. Other people, so people don't necessarily go through this in a very linear way. It needs to provide a way of describing how people can change with apparent suddenness. So it basically was arguing that and they cite evidence that there's theoretical problems with it. If you look at systematic reviews, trials that compare trans-theoretical model-based interventions versus non-trans-theoretical model-based interventions, there's no difference. In fact, even systematic reviews of trials of trans-theoretical model interventions versus control, no difference. And he just sort of said we need to stop, because if you go to lots of health promotion departments, that's what they talk about. And it may not be useful. So we can test theories to death. If we do, we learn something. Okay, it's a good thing to actually sort of move and discard them. Interestingly, this was the start, and I had about 6 responses, invited responses, including by Prochaska. So it's a really interesting series that's worthwhile probably reading. Some of the other issues that we've talked about is we need to find ways of making behavioural and other theories accessible to non-behavioural scientists, and we need to develop then, I think, practical theory-based tools that non-experts can use. And a couple of examples we talked about with the theoretical domains framework, where I don't think you need to be a psychologist to be able to make sense of it. And also Susan's got another model called the behaviour change wheel, which I'm not going to describe in any great detail. I have to confess I like the theoretical domains framework. I talked to Susan. She probably likes behaviour change wheel better. I see the behaviour change wheel as very useful for talking to high-level decision makers rather than people who try to plan detailed programs. But both of them are potentially valuable to getting across core psychological ideas in a relatively accessible way. We have a failure to build informative science. We have thousands of studies that provide flawed or limited information. In cluster randomized trials or cluster allocated trials, clustering is normally ignored. There's a small number of units. We have unrealistic effect sizes, and unit analyses remain common. That's something as a research community we have to own and we have to just address. It's no longer, I think, acceptable to plan a study and ignore some basic methodological issues. As we talked, I think, in the 3rd session, the majority of studies are 2-arm trials of intervention versus control that I think provide relatively little or not as much information than if you either have multi-arm trials or different types of designs where you're trying to get more information out of them. Interventions are badly designed and poorly justified. People don't try to look at causal mechanisms. People largely ignore economics. And reporting is terrible. So all of these things are, just dog the area. I mean, if you do systematic reviews of these interventions, you come out depressed because you find that there's consistent evidence of not great science, which is not something we should be proud of. We should be able to do a lot better than this. I think that problem is relatively easy to fix. I think this is a more worrying problem, which is a failure to build cumulative science. We have thousands of studies that don't optimally incorporate the current state of knowledge when planning new studies. So one of the ideas about science is you say, well, what do we know now? What do we need? What's the next question? Let's go try and answer that. Let's think of the answer in context of what we know now, and see if we've advanced knowledge. Okay. So you might imagine that if we tested, say, A versus B and B was better, then future studies would have B as a standard of control or your standard of care, and you test B versus C. What you find is that actually it's much more messy. So if you look at ordered feedback, there's a strong theory that's empirically based that would suggest that things like providing targets and eliciting plans help people to change their behaviour in response to ordered feedback. But by 2006, of 118 RCTs of ordered feedback, only 28% used any of these elements. So this was knowledge that we knew, and they're just not being incorporated. And the sense you get is that people, basically just make up their own ordered feedback. So just sort of sit down one day and play with the computer, and this is what comes up. without recognising there's an extant body of knowledge that can actually likely make that more successful. We could say that, I mean, the same in the large diabetes QI reviews. This is one of the reasons why actually doing these reviews can be frustrating, because you just feel like there's this constant sort of churn without really making much advancement in the field. And also, by September 2009, there were 35 systematic reviews of reminders. Why do we need 35 systematic reviews of reminders? We probably need 2, 3, 4, 5. Our replication is a good thing, but actually what we're getting now are people just sort of basically doing systematic reviews of questions we know are answered, and wasting resources, wasting space in journals. Yeah, it's not good science. I think did I show you this before? So this was a cumulative analysis of the audience feedback review, so it's not forthcoming, it's been published, where it's not a sort of traditional cumulative meta-analysis, but this is a cumulative analysis where we're describing the point estimate and the interquartile ranges, and you can see that really, wherever you want to say, certainly probably the last 30 trials have really given us no new knowledge, given our available methods of analysis. This is a real problem. The cost of 31 of these trials is not insubstantial. They probably weren't planned well. They didn't use good knowledge about how to optimize audience feedback, and they're done. And you put Sigma in a systematic review, and they make no difference whatsoever. So failure to replicate these to promotion of potentially ineffective interventions or abandonment of potentially effective interventions. And it also leads to wastage and inefficiencies in the research enterprise. One of my fears is in 5 or 10 years' time, funders will turn around and say, we've just spent all this money over the last 10 to 15 years and you've wasted it. You've not made an advance in our knowledge base because you've been doing bad science. And they'll walk away, and they will be right to. So again, as a research community, we have to take this on. Noah Ivers is a family doc in Toronto I do a lot of work with, and we kind of convened an international group to actually talk about what was needed in audience feedback, and particularly talked about sort of the need for head-to-head trials that would compare different ways of delivering audience feedback, and building upon the extent evidence base. But I think we need to challenge ourselves each time we plan one of these studies in terms of to what extent are we using existing available evidence, and to what extent are we moving the science forward. If you just go back to my comment about funders, I think there is an issue about research funding. So what you find globally in a lot of countries is that knowledge translation and implementation comes up on the agenda for a few years, funders put money in, and then they've done it and it goes away. So the UK NHS R&D had an implementation research program, and it spent £7.5 million, and then it just stopped. And there was an evaluation of the program, an independent evaluation. I was involved in chairing the commission group. But when the independent evaluation talked to the researchers, they said, this should be the starting of the funding. To some extent, we've learned so much, and we need ongoing funding to allow us to sort of continue and really generate a useful knowledge base. So the problem about these sort of things where funding pots come up and go down is, first of all, you sort of you disperse the group, and you don't build up the expertise, and you also don't cumulatively build up knowledge. So there is a question about what proportion of global research budget should be spent on implementation research. I was a plenary speaker at the first NIH conference on dissemination implementation. I can't remember saying this, but I'm told by people I did. I sort of said, well, maybe 50% of the NIH budget should be based on this area. And that apparently caused a few ripples in the audience. The good thing is, actually, for the NIH is they now have a standing panel for dissemination and implementation research. Once they make that commitment, it's very hard to take a standing panel back. So they're one of the few funders globally that said, we think we're going to consistently invest in this area. That research panel, the dissemination implementation panel, is not just for US-based funders. So I don't think they've funded a lot of stuff outside the US, but if you talk to people who run the program, they say we are interested in getting international grants. And they're very happy to also, if you like, train you about how to apply to NIH. And there's different levels, and you don't go to NIH first time round asking for the $2 million a year grant. You start with the $50,000 for 1 year. You build up, but there's ways of building your track record. It's not clear to me, from having been here for 3 months, who, if anybody, would fund this kind of work in South Africa. And the colleagues who've done it seem to sort of manage by either contorting themselves to fit into this competition and being able to then get the funds and do what they want to do, or just being very, very nimble about it. So I think there are issues that as the quality agenda becomes more important, what are the arguments with funders about this is a priority that we have to invest in?
MRC's just put out a call for TB-related implementation.
Great,
so they're
good.
recognizing, and they we obviously get donor funding, other funding from Gates and
Yeah.
whoever.
Good. Well, that's great. So what we'd hope is the next generation of people who apply to that use existing knowledge and try and advance the science, and so that we, the MRC will feel good that they invested in this and got sort of useful information back.
There are quite a number of CDC and WHO have funded quality implementation, but then it's also private people, but it's, as you say, extremely fragmented.
Yeah. And some of the things are more for doing rather than evaluating, which is a bit of a challenge. Okay, I think this might be my last challenge. I guess today I'm a bit half empty, I think. I'm not sort of hugely optimistic about the world. One of the interesting things is I've been doing implementation science for the last 25 years. I'm not the person who's then going to do kind of this in a service setting. I'm trying to generate knowledge that people who've got responsibility for this in a service setting will use. So we have to think about what I'm going to call the I-squared challenge. So implementation science is constantly producing new findings that could contribute to more effective implementation, but this research will not change evidence use unless receptors in the healthcare systems adopt them in practice. So how do we make sure that our evidence is actually, that we're generating, is influencing the people in the healthcare system that will actually be potentially using this? And I would say, and I'm very guilty about this, that I think one of the issues is that implementation researchers have not convinced healthcare systems of the utility of our scientific insights. People aren't coming knocking on, well, some of them are, but people aren't coming and knocking on our door saying, tell me what the latest research is and about how I should do education, implementation. People just get on with it, and that's one of the reasons why we don't get this sort of cumulative building. So one of the things I've been thinking about is, well, who are the potential receptors? We've been doing some work in Canada with continuing professional development. So family doctors in Canada spend 1.5 million hours a year engaged in some form of continuing professional development. It is probably the single most investment they do in anything around, improvement or whatever. In Canada, the vast majority, certainly in my local patch of continuing professional development, is short didactic lectures by experts on interesting things they think about. Probably not maximizing the likelihood that family doctors are going to leave those sessions with knowledge or skills that's going to be helpful for improving the care they provide for their patients. We did a session, we developed a session on managing low back pain. And guidelines say you shouldn't image them, you shouldn't do x-rays, and you should advise people to stay active. And if you talk to family docs, they say, well, some of the problems are patients want x-rays, and so I just give in. Or I don't really know how in detail to talk, how I really sort of negotiate with the patient about exercise. So what we were doing is based on work we've done in Australia, was a sort of an hour-long workshop which would actually provide some knowledge, but a lot of skill development. At the same time we were doing that, a very, very pleasant radiologist in Ottawa was developing his 20-minute GP update on back imaging. And he was going to show the GPs 50 slides of really rare things that you can pick up on back x-rays. Okay? Things that the average GP would never see in 10 lifetimes. Which is kind of giving the wrong message. If you want to avoid these things, you don't sort of say, oh look, If you look really carefully, you can find this really weird neurotumor that is 1 in 27 million people every 10 years. So the problem at the think about sort of continuing professional development as something professionals engage in, and something that we might be able to use much more creatively to train people or to bring people up to speed than a lot of the didactic work that happens at the moment. Quality improvement groups. Buzzer and Gary Cantor invited me to the Quality Summit of the Hospital Association of South Africa when I first arrived. Lots of really interesting kind of work ongoing. There are often quality improvement groups have a set of techniques that they've been trained in, and I don't think it represents the full range of things that they could do. So, but they've got resources to try and actually improve implementation. So why aren't we trying to engage with them in a way that will sort of, I think across all of these will be mutual learning. We'll learn things together. Risk management and maybe others. So I think we need to start thinking about how to reach out and engage with these groups, and there's significant mutual learning opportunities through better engagement. And it should protect implementation science from ivory towerism. I think fundamentally this is about, what I do is about helping solve problems and generating knowledge along the way. And I do worry that there's an increasing emphasis on doing this in a very academic way, which is kind of quite divorced from the realities of what's happening on the ground, and you'll end up with a very sort of academic body of evidence that isn't particularly helpful for these groups. Okay, so those are a series of challenges that, particularly people like myself, I'm going to say Chrisella because she's been doing this for a while, we have to try and, I think we have to be very honest as scientists in terms of what we've done to date and how we can do science better. And we need to push ourselves, and we need to push our colleagues to do that. Okay, that's probably the half-empty stuff. Let's think about the half-full stuff. I said implementation science is a relatively new field, and when I was in Australia earlier in the year, I was asked to do a presentation at a workshop by University of Sydney about how you could develop the field. There's a famous sort of saying by Bill Clinton's financial advisors that what's going to win the election, and they said it's the economy, stupid. Okay, I would say in terms of developing the field of implementation science, it's the science, stupid. We need to really be ambitious in the science that we do and push ourselves as much as possible. Whoops. And these were, so this was to a group of probably about 50 or 70 people from the University of Sydney. And I said we need to be ambitious. You see an awful lot of people who are not particularly ambitious. They did this once, they'll do it again. And they'll still do it at a relatively small scale, and it's not really advancing any new knowledge. I think we have to be bold and ambitious in what we do. We need to be rigorous. We should not. We should be ashamed if we are publishing papers that have got basic methodological flaws. No one would do that, but people should be ashamed. We need to be thoughtful and cumulative. We need to try and build upon existing knowledge. We need to be collaborative. I can't think of a study that I've done where I could say that either the one single centre has the right skill sets and the right networks to be able to mount a large-scale study. So this is not an agenda that you can sort of say, I'm going to sit in my office and not talk to anybody and actually make advance. We need to be engaged. I think we need to be going out and talking to the field, learning from the field, and making sure that our science fits around the needs of the healthcare systems trying to make sense. And we need to be committed. As I said, I think the field has taken off probably in the last 10 or 15 years. Before then, what you would, I had this stereotype, which was I'm a great clinical diabetes researcher, and I wake up one day and think, I know, we need to get those damn GPs to do this differently, so I'm going to basically educate them. Because I'm a scientist, I'll do a trial. I do a trial, and I find that actually, doing an implementation trial is very different from doing a clinical trial. and actually the results aren't, my brilliant attempt at teaching doesn't make a big difference to them. So I don't ever do that again. I go back to my clinical research. We have a lot of people go in and out. And I think, if you want to, if you want to make a difference in this field, you need to kind of commit. You need to sort of say, I'm going to sort of, be in this for the long run, because you learn, your experience is huge. I mean, when I talk to people now, I've got kind of a backlog of something like 40 trials. And you have this amazing sort of, well, is it a bit like this? Or, we've done that before. I mean, Priscilla and Dinky must be kind of similar in terms of, there's a lot of, you will then draw upon a career's worth of knowledge, rather than this is the first time I've tried to think about a cluster trial, the first time I've tried to recruit rural clinics. So I hope, and certainly in Canada, I see a generation coming through that I think will do this. I think we also need to maximise learning opportunities. One of a framework that Martin Eccles came across at some point in time, so we stole it, was that all projects could, and actually should, advance substantive knowledge. So let's say we're doing a trial about how to improve paediatric care in rural settings. Hopefully our studies will tell us how to do that. It'll actually contribute to our understanding about how to improve paediatric care. But it can also help us think about conceptual knowledge. So what's the kind of theoretical, how does it advance theory? How does it advance our broader understanding outside of the specific setting that we tested this from? And it can also advance methodological knowledge. I have not done a trial where I can go to the shelf and just pull out the methods. Virtually every study I do, there's some additional methodological development. And quite often what happens is, because we're very busy, we write up the substantive contribution and we never write up the methodological contribution, which means that someone else is going to come behind you and have to do the same thing again. So we should be recognising, particularly when we're doing large projects, what are the things we can do? We've routinely, with methodological knowledge, for example, embedded trials of different sort of ways of, if you're using surveys, trials of different survey administration techniques. What happens if you have financial incentives? What happens if you vary them? You can embed that sort of stuff quite easily into studies without undermining the sort of primary purpose of the study. So thinking about those opportunities, about how can we, the substantive knowledge should drive it, but at the same time, how do we learn something about the underlying theoretical understanding of the world or methodological understanding of the world while we're doing that?
Sorry, what do you mean when you say substantive?
It's actually the kind of content knowledge, okay? So, if you take the example of, we do, tomorrow and I are in Kenya, and actually tomorrow I've left, but I visited somewhere called Kemri, and they had done a cluster trial in 8 hospitals about aspects of paediatric care. I could demonstrate that with their implementation strategy, they improved, fundamental sort of aspects of paediatric care. That's a substantive knowledge. That's the kind of stuff that you might as well say, that's great, okay, if we want to try and improve paediatric care in Kenya, we might want to try and either roll that out or scale it up with something else. But at the same time, you could learn something about, Michael and I have had conversations about research in emergency settings. And I think there are probably quite unique challenges in emergency settings because of the acuity of care, and the lack of follow-up, the chaos of the environment, and also we know that there's probably a much broader range of cognitive biases coming into emergency care than in, say, general practice or internal medicine care. So if we're going to do a study in an emergency setting, whether it's pre-hospital or hospital, we might want to think about all the things that we can learn, think about sort of what the peculiarities are of emergency settings. Why is it similar or different? Or if we recognise that actually the major, one of the major issues is cognitive bias, use that knowledge base to think about designing our interventions and what are the ways of trying to de-bias. So it's that kind of approach. And I don't want to make it too. I think I normally start off with the substantive issue, but as I'm doing a study, there's always things that pop up that would contribute to the theoretical or the methodological, and it's just making the most of those, and then also trying to write them up so they don't just become things that you've learned; they're things you're sharing with the world. This is something I've been thinking about for a while, but there's some relatively new thinking this year, most practical. And that's the idea that we probably have to change the way we do this research. So across my career, most of the research I've done has involved one-off projects. So, someone approaches you, you think, yeah, that's a good project. You have to put together a research team. You have to go out and get the funding. You then sort of basically have to negotiate access to the healthcare system. You then do the study, and then you write up, and you normally write up outside of the funding period because you kind of run out of money. After the money's gone, the research team disappears. The healthcare system says, that's really interesting, very nice, but really doesn't take any responsibility for saying, well, actually, maybe we've learned how to improve pediatric care, maybe we should do that. And so it creates problems with efficiencies for the research team, the healthcare system. There's a failure to maximise learning from individual projects because you don't write things up, because you're exhausted and you've run out of time and you're trying to get the next grant. There's a failure to communicate learning from individual projects. There's also an intellectual discontinuity. Your team disappears. Now, a lot of us will work serially with the same people, but that's often through kind of personal relationships and the kind of commitment we have to work together, rather than the idea that structurally, a team working together will actually start to build a much better cumulative understanding of the world. And it also it creates problems with promoting interdisciplinarity, that if you want to work with different disciplines, it often takes you 3-5 years to work out how to talk to each other. And if you're coming up and going away, you may never get there. And so we don't get the richness that we get from having different disciplines. So what sometimes happens then is you get kind of team funding. So you can get a research team where you get programmatic funding to undertake multiple linked research projects to develop new substantive methodological and conceptual knowledge. This does reduce the problem relating to convening a new team, seeking project by project funding, potentially or conducting study, potentially writing up and promoting interdisciplinarity. But you often still have to access within your research team the healthcare system for each sub-project. And so there's still a set of issues around how you're actually going to run that. The example I've got here is Knowledge Translation Canada. I was the PI on this. It was a network of about 50 implementation scientists from 6 centres in Canada, and we got $13 million, $3 million for infrastructure and $10 million for operating, that funded 17 projects and had a training program alongside it. And it was great. I actually spent most of my time signing checks for other people, which wasn't for me the best scientific experience. But I don't think it was necessary. You didn't get a lot of, it didn't help us engage with the system. Each project was having to go out and build the relationships with actually access the system, and so there are issues around that. So this has led me to the idea that we need implementation research laboratories, where we have research teams that are integrated in healthcare systems, that are undertaking programs of research directly relevant to the healthcare system's priorities. And I'll describe what I mean by that, but this I think addresses virtually all of the problems I talked about. And it also allows opportunities for formal and informal linkages of mutual advantage to the research team and the healthcare system. You actually get to know each other, you understand what are the kind of realities of people working in the healthcare system, and also what knowledge they gain by, through their experience. They'll start to appreciate the research team further. The other thing about this is it also potentially explicitly recognises the roles of the research team in the healthcare system. So in implementation laboratories, I see it's the healthcare system's responsibility for delivering the intervention. So if the research team leaves, you still have the opportunity in the system to actually keep it going. So let's apply this to the idea that you have to do audit and feedback research differently. 140 trials, interquartile range of 1 to 60%. Got some information from indirect comparisons about what makes audit and feedback more or less effective. But if we really want to make sense of the field, we want to get beyond questions of does audit and feedback work, but to understand how do you operationalize it so it makes more of a difference. So future studies need to compare in head-to-head trials different methods of delivering audience feedback. We may vary timing. Let's do this 3 monthly versus 6 monthly. Or let's make sure we're using data that was collected a month ago, so it's salient to the practitioners rather than data that was 12 months ago. The design of the audience feedback, is it cross-sectional or is it longitudinal? The content, do we add notes around that? The delivery, who actually delivers it? What about co-intervention? So there's a whole, there are probably, I don't know, there are probably, well, there's a finite number, but a large number of secondary questions, if we can answer them, would allow people thinking about delivering audience feedback to be more effective in their audience feedback. So within an implementation laboratory, you could embed head-to-head trials and routine health system audits that then sequentially test different ways of delivering audience feedback. So, you start off, so the National Prescribing Service I'll use a real example, or a live example. The Blood Transfusion Service in the UK routinely does audits of blood utilisation in hospitals. They've been doing this for probably 10 years, but they recognise that to some extent when they're doing it in a rather arbitrary way. They don't have a good evidence base about how they should deliver the audience feedback. So you could say, let's work with them, and you do what you normally do. Let's do your audience feedback X as the baseline condition. Now, we'll work with you, and we'll actually sort of see whether we can change some aspects of audience feedback in a way that we think might improve user effectiveness. So we'll develop audience feedback Y. So we then test in a head-to-head comparison audience feedback X versus audience feedback Y. The healthcare system is already putting the intervention out there, so the marginal cost of having a second intervention is probably very, very small. And you find that audience feedback Y is better, that becomes your standard of care. That's what the healthcare system does. So you then test audience feedback Y versus audience feedback Z. Audience feedback Z is no better, it's more expensive, so you don't do that, you abandon it. You've learned from it, you can move on. Or you could say, we'll look at audience feedback Y versus audience feedback Y plus a co-intervention. Does a co-intervention incrementally add to the effectivity of the individual trial? So the idea is that you kind of embed these sequential trials. And once you've done one trial, the results of that trial inform your control condition for the second trial, and also what your next hypothesis may be. And within this, you can see that I think there's different responsibilities. So I think the healthcare system should define the priorities. We're interested in chronic disease. That's fine, good. Okay, well let's work with you on whatever you think is important. Because the content probably doesn't matter that much in this setting. We're interested in advancing the kind of conceptual knowledge about how to deliver audience feedback. So the healthcare system also develops one version of your prototype audience feedback. But then as a research team, you also involved in sort of what else should you, what are the other things you might want to vary. The healthcare system delivers the audience feedback, captures the data for you. The research team analyzes the data, and the healthcare system and the researcher should interpret it. So the marginal cost of doing these, research cost of doing these trials is relatively modest, because often the big cost of doing the trial is the delivery of the intervention and the data collection. If the healthcare system is already committed to doing that, and they'll continue to do that, then you're also saying we want to sort of find funding for the marginal costs of doing the development of the prototype audience feedback, maybe any marginal cost of delivering the second time of audience feedback, and the analysis side of it. Okay? So the benefits for the healthcare system, you say, this is part of being a learning organization. We can work with you to, you can hopefully demonstratively improve the impact of your audience feedback. So whoever's funding you, you can say, well, actually, in the last 5 years, we've improved the effects of our audience feedback by, about 4 or 5%. And at the same, so we can demonstrate it. It also gives healthcare systems essentially access to academic experts, which is often a kind of really valuable thing for people. For the benefits of implementation science is that we can test important but potentially subtle variations in audience feedback that may be important effect modifiers. So if you wanted to test audience feedback which is delivered or which is based on a cross-sectional delivery versus longitudinal delivery, I don't think that you'd ever get a research funder, to pay for that. Because I'd say it's just too, it's kind of dancing on the head of a pin. But it might be really important. if you wanted to, because it's a head-to-head trial, your sample size requirements go through the roof as well. So again, if you wanted to do a subtle test of A versus B, you'd have to have a large sample size. Healthcare systems have large sample sizes. Researchers trying to improve practices often end up with small sample sizes. So opportunities to sort of make our science more feasible and more informative. So this is an example. The Affinity study is working with the NHS Blood and Transplant Service. It's a 5-year program, and we're doing a 2x2 factorial trial testing different ways of delivering, or designing and delivering the blood utilisation audits. And it's quite remarkable. This is some of the kind of common sense things that people don't recognise. So this would be seen as a good audit program in the UK, but apparently the routine audit and feedback is normally a 100-page booklet, and the actionable stuff is embedded in there. So on page 33 there's one graph you should respond to, and on page 66 there's another graph. And one of the things that the psychologists are saying is, well, we should shorten it, because no one's ever going to read a 99-page document, and we should put what you want to look at. And so there may be some really sort of simple things that could enhance the work. But because we're working with the NHS Blood and Transplant Service, we can analyse 152 hospitals. If I was a researcher trying to recruit 152 hospitals, I would give up after about 3 years. So it really helps with feasibility and testing things at scale. And then the other thing that I'm quite excited about is, I said, we have an audit feedback lab with the UK NHS Blood Transfusion Service. We currently work talking to the National Prescribing Service in Australia, who's got an audit feedback program, and they want to play with us. We're talking to Health Quality Ontario, who are delivering audit feedback, and they'll play with us. So we may end up with a range of different laboratories. You can also do it at a relatively low level. In my hospital, there's an anaesthetist who is using sort of routine data captured in the perioperative period to provide feedback to anaesthetists about temperature regulation. And he's doing cumulative studies. But one of the ideas is, how do you maximize the learning? So the idea is you form a meta lab. Okay? You have something that says, we're going to put a structure in that will help us learn maximally across these areas. And in your meta lab, you bring the best minds in the world who are audio feedback experts. So Susan Meekie, my Scottish goddess, agreed about an hour ago to be in the meta lab for the National Prescribing Service study. We're going to have to get funding for it. But you start to bring together an expertise with the healthcare system partners, and it allows you to say, well, actually, in the UK, reducing the audit feedback and making the actionable information much more accessible seems to improve its effects. Why don't we try that out in Australian general practice? So you can start to think about, well, can we embed replications across these different settings? Our experts will sort of say, well, here's the things you might want to manipulate. And so you can think about cross-lab learning. You can think about replication. You can also think about prospective meta-analysis is probably too strong, but some sort of prospective synthesis as we go forward. Okay? So this is what I'm hoping that in the next kind of 10 years, I spend a lot of time trying to develop. And I don't care where they are. So if there are groups in South Africa that are routinely providing audit feedback, and you think they'd want to play with us, great. And what we say to them is, we will hook you up to some of the best experts in the world. We'll, at the baseline level, we'll try and get your audit feedback as good as it can be, and then we'll routinely test things. Yeah. As long as and where there's a real shared understanding. So as we just talked to the National Prescribing Service in Australia, one of the key issues we said is you have a veto on anything. It's not the researchers coming in and saying you have to do research this way. It has to be facing your view, your issues, and you can veto things, and we'll live with that. So we have to build these relationships. Here's a different type of thing. What I talk about at the moment is largely a single intervention laboratory, but here's another laboratory that I've been involved with, which was probably the first one, which is in Scotland. So the Cochrane people might know Jan Clarkson. She's one of the coordinating editors of the Oral Health Group. And she is the leader of something called SDCEP, which is something like the Scottish Dental Clinical Effectiveness Programme. Gosh, I can remember the acronym, that's good. But that's developing guidelines for community dentists. Some of them are procedural about how you decontaminate your equipment, others are about things like clinical issues like antibiotic use. So that program was established, and we went out and got additional funding to establish alongside it an implementation research focus. So that as SDCEP developing guidelines, we are doing a barrier assessment using behavioural approaches of the recommendations as they're coming out. And what it means is, first of all, we have a much richer understanding about what the barriers are, which is kind of useful for the healthcare system. We think these are the kind of issues you're going to face. And we've done things where we've used that to help the NHS to deliver programs. So in the decontamination study, Scotland already had a sort of workforce going around helping dental practices set something up. But our information was kind of plugged in to improve the effectiveness of that. And I think we tested that either in a simple before or after, or really not a very robust evidence base. Or you could also design research interventions on that. So Triad has just done a trial of ordinance feedback for antibiotic prescribing in dentistry. Dentists are huge prescribers of antibiotics in the community, and often they're over-prescribing, and found that you could reduce sort of ordinance or antibiotic prescribing by 6 to 8%, I think. And I'm trying to say to Jan that that's great. We should get the Scottish Health Service to provide ordinance feedback to dentists routinely. Then we can set up an ordinance feedback laboratory. But yeah, so you can have content areas as well as, and to some extent, although it's not been set up as a lab, if you look at the work that Dinky and Chrisella have done, it's been within a certain span over a period of time. So it's got some elements of that. I think we can think about, can we do this in a content area? Can we do it within an intervention area? Okay, so I think that's a different way of working. And then last year, I think I'm kind of getting towards the end.
Jeremy, can I just
Yeah, sure. Absolutely.
My question always is, who pays for, how do you set up this platform? Because the health service is not going to pay for it. You must come in as an independent researcher with resources of your own.
Yeah.
Initially, at any rate, I would think. So that to me has always been quite a handicap. I mean, the minute we had funding for such an assessment, it would roll. But we had to find more funding.
No.
And usually international funding.
So I can tell you, outside of a South African setting, we're going out and finding funders who'd be sympathetic. So the NHMRC in Australia has a partnership funding model where they want academic service collaborations. So we're going to go there. At the moment, we'll have a letter of intent for the Ontario one for a funding pot there. The arguments we're kind of making, though, first of all, from the this is going to help the healthcare partner to do a better job, but it will generate knowledge that is useful, and the costs are relatively modest because you don't have to take the full cost of recruiting 3,000 practices. You can basically do these other costs. So it doesn't take. I think the researchers need to be able to come to the table and be prepared to say we'll find the marginal research cost of doing this, and that may, in a setting like South Africa, be a challenge given some of the funding issues. But you can see. So I'm clearly open. So I've got potentially one in Canada, one in the UK, one in Australia. Who knows where else? I'm looking at that level, and if you can't do it in South Africa, that's terrible. I'm really sorry, but I don't know. Rwanda, they can do it. I'll go and play with Rwanda. It's one of those things. I mean, as a kind of scientist trying to build a base, look for the keys, or look under where the lights are, rather than sort of peering around the darkness. So, yes.
Can academic institutions go start to create competencies starting to move into a clinical lab in British Cure. But this idea was just foreign news to people, of actually having translation labs and starting to look at implementation.
So let me keep going.
Great.
Okay, so I think I've already said this, but one of the other issues is about collaborate. And that, I think the other thing is there can be different types of collaborations. There can be collaborations at the kind of individual research project levels, but I think we also need to think about how do we work together more in a community. So I have a colleague in Alberta called Carol Estabrooks, who's from nursing, and a lot of her work has been about understanding team functioning and how that impacts on knowledge research utilization, is what the nurses call it. And Carol and I had a kind of conversation very early on, because I've knowledge behavioural stuff and it's quite individually focused, and could be, I'm a physician, I've done a lot of work with physicians and we're kind of much more individualistic, nurses are much more team building, and it could be an explanation about why we have slightly different perspectives. And also we're using quite different theories. Carol's bringing a lot of organisational psychology in at the team level. And we had this conversation that says, actually, this is great. Because I can, we don't have the skills that would allow us to look at both the individual and the team level stuff. So why doesn't Carol go and spend 5 or 10 years working over here? I'll spend 5 or 10 years working here. We'll keep talking to each other. But at some point in time, we can probably start to sort of bring a shared understanding together. But no individual team is going to have all the skill sets to address all the questions. But if we know someone is, Carol is working on that area, and she's a really good researcher, great, because that then means, as long as I'm kind of tracking Carol and keeping kind of communication channels open, at some point in time, I may want to, we might want to do some collaborative work because both of our researchers got to a certain level of maturity. Okay. What I've said. Katie Card is a view of a national collaboration. So the nice thing about this is that it really did encourage sort of cross-university collaboration in a very healthy way, and it's developed a cadre both the faculty, and also we've done a lot of capacity building, which I think is very exciting. There's an opportunity for international collaboration. So. This was some of the early work we did with the theoretical domain framework. Jill Francis, who's an Australian goddess living in London now, was in Scotland at the time, did a TDF study looking at intensive care about determinants of blood product use. But we had a joint Canadian-UK team. So that what we did was we basically developed a shared protocol. And we went and used the same protocol to collect the same data in Canada, which allowed us to start to do a compare and contrast. We had enough data about what's happening in Canada for it to be relevant in Canada. We had enough data about what's happening in Aberdeen for it to go in Scotland to be relevant in Scotland. But because we used the same protocol and we had a shared team, we started to say, are there different factors that work across these different settings? So prospectively sharing sort of approaches, I think is worthwhile. And that was a Canadian study, but also we did this sort of cross-country comparison. Here's another example of an international collaboration that's been led by Michelle Benson from the Netherlands. This was a European Union funded project where in 5 countries, the plan was to do a tailored a study of a trial of tailored intervention for chronic disease management. Each country was allowed to define what the priority was for that country, but there's a shared approach in terms of, well, how will we assess barriers, how will we design an intervention. Let's run the trials together, and again, some opportunity for learning. So the protocol wasn't as tightly specified as maybe the theoretical domain framework was, but you still have the opportunity for cross-project or cross-country, cross-project synthesis. So coming now to sort of Alson's comments, one of the things that we did with Katie Canada and our training initiative was to start to think about what the core competencies would be for both the science and practice of knowledge translation. So we identified 3 different groups. People who want to be knowledge translation / implementation researchers, what do they need to know? What do researchers who are just sort of any kind of basic clinical, biochemical, or biomedical researcher, what do they need to know in terms of making sure that they're as effective as possible as they can in terms of the translation of their work? And then the third level was for people like policymakers or users of our knowledge, what do they need to know? Okay, so kind of different levels around that. And in KT Canada, we have actually worked at all those levels, but the thing that I'm probably most proud of is that we, for example, run a summer institute for the last probably 6 years, where each year it's a week-long institute, well, a 3-day-long institute, about 30 faculty, 30 students, which we take from across the country. We often provide support for them to get there, and we have a mixture of sort of expert presentations, workshops, didactic sessions, but also a sort of interactive sessions you go through. Okay. This is this is Melissa Shamsi, who's currently a PhD student of mine, presenting a poster. I think that was pre her PhD, when she was just planning a PhD. So I'm also giving kind of students the opportunity to present to, in this case, Julie Little, who's the head of epidemiology in Ottawa. Yeah, a lot of close contact between really, really good scientists and staff. This is also from the same, or from one of these institutes. This is Susan Meeky. This is the Susan Meeky here. Okay, you want to know what she's like? Yeah, but she's sitting with Brigitte Vachon, who is who did a postdoc with me, Janet Curran, who did a postdoc with me, Andrew Bouchier, and Noah Ibis, and who I helped supervise their PhD. So again, just an amazing opportunity. I go on about this sort of this Scottish goddess living in England, and we put people in the room with her. And yeah, it's remarkable because well, you can see. I think people are kind of quite interested in what she's got to say. But there's an issue about building career paths. So all of these people did either PhD or postdocs in knowledge translation related exercises or avenues. There really aren't faculty positions for implementation scientists, because we don't have departments. Apart from the Netherlands, there's one department. But actually, each of these managed to find a career path for them. But we have to think about, can we do this more systematically. Brigitte is an occupational therapist, and she's now in an occupational department in Montreal, where it's accepted that she's going to do this kind of research. Janet is a nurse, is a professor of nursing in Dalhousie unit in Dalhousie, where again there's actually quite a strong recognition. So we've had to develop career paths where people have their foot is in the discipline, but you explicitly sort of try and craft the position so they can say, but my contribution is going to be, I'm going to do this stuff. So we really need to think about how we do this more. My worry in Canada is producing these amazing people, and they're nowhere to go. They've got nowhere to go. And so one of the other things is, particularly for people who may be then going into a disciplinary base, we also have to think about how we mentor them, so they're supported in the implementation science thing, at the same time hopefully they're getting kind of support within their nursing or OT or chiropractic settings. This is a kind of an aside, but one of the issues that that was helpful for me, but actually that other people found helpful, was I think if you're planning a career, you have to have a coherent story about what your career is, even if it isn't coherent. You have to be able to sort of say, well, this is kind of how I see the world. And I have a colleague in Canada called Mitu Majumdar, who is an amazing implementation scientist, endocrinologist, and he says, I work in diabetes and osteoporosis. And I only work in diabetes and osteoporosis because I think if I worked in other areas, in my institution, if people looked at my CV, they would think I'm all over the place, and that would be seen as a bad thing. And I think I said this to me too, that that's a real shame, because he could make a much bigger, well, he's making a great contribution, but actually, there's people who are 2 doors down from him are rheumatologists who probably couldn't benefit from him because he's sort of saying, actually, I feel I have to be constrained this way. So I think there are decisions that if people are interested in the area and what you want to do, you can either say, I can do implementation within a certain sector, and that's fine, because potentially you can make a lot of progress in that sector. Or you could do what I've done, which is say, I see the sector as being, or the clinical concept area, being part of the context. I want to work across contexts. But if you want to work across contexts, you have to have a way of describing that that's coherent. So for me too, it's very easy. I'm an implementation researcher who's focusing on improving the quality of care for patients with diabetes, patients with osteoporosis. And I'm an endocrinologist, which is why I do those. Okay, I get that. So one of the things I did fairly early on was to sort of define my program in a very broad way and said, the aim of the program is to evaluate different dissemination and implementation strategies to promote the uptake of research findings. And the program includes these 4 areas: systematic reviews, rigorous studies, methodological research, support of service development. And I think it had a statement that sort of said I work across different conditions, different settings, because I think it's really important that we understand how the discipline or the problem is an effect modifier on the effects we see. But I think one of the things that you might go to more, due respect to Southern, more junior people in the room. Hello, Elizabeth. And me. If you want to sort of set out, then it's really helpful to have a way of describing what you do relatively concisely and coherently. And then if someone says, well, why on earth did you do that work with the dentist? Well, it's a trial that tested financial incentives for healthcare professionals. So although you might think it's a bit weird when I was working with dentists, I could test financial incentives with dentists within this setting, which I couldn't have done over here. So it allows you to articulate your story as you go forward. And I guess the other thing to say is whenever one does that, my mental sort of view is 80% of my research has to be able to fit into it, and I've got a 20% which is just mine. And as long as it's a kind of minority activity, it's fine. So at the Afro Implement project, I saw as being largely my sort of, thing that I could probably fit within this, but actually was something which was a side project, which was just really interesting. A few other things about developing the field of translation science. We now have a core journal, Implementation Science. This was founded in 2006. Before then, you could, if you looked at my CV, you'd find that things were published all over the place because you'd publish it where you could. And you could get trials into major journals sometimes, Lancet, BMJ, JAMA. But it's also really hard to get, say, the methodological work or the conceptual work published in those journals because that wasn't what they were interested in. So implementation science was formed from people in the European project and the VA coming together. And Martin Eccles and Brian Mifflin were the first editors-in-chief, Martin from the European project, Brian from the VA. And the idea is trying to create a space where people could discuss often the early work, the conceptual work, the stuff that we tried and didn't work very well, and maybe we should learn from that. And I think it's been pretty successful. Particularly within a 5-year period to get an impact factor of over 2. It's more than that now, I think. I don't know what it is, but it's kind of quite remarkable. It also demonstrates there's a community that looked at that. Okay, so that's it. Just to come back, Richard Grohl, who's a data psychologist, who's very influential in establishing kind of quality and improvement science in the Netherlands, in Europe, says, the evidence practice gap is a public health crisis. People are going blind because their eyes aren't being screened, and we know they should, and we've known for 30 years, something like that they should be screened. That's a major issue. So implementation is about saving lives, improving outcomes and quality of health services. Implementation of science is relatively new field of health services research, and we've made a lot of great progress. I think I've said this before, but when I started in the field, the BMJ and Lancet had editorials saying the only way you can change what physicians do is to wait for them to die or retire. Whereas actually we have thousands of studies that show that it is entirely possible to improve quality of care. That people working in quality care in healthcare systems aspire to provide high quality care, and if you can help them, then they're very willing to do that. But there's a long way to go. If you're being half full, I can do a very good story about how much further on we are now than we were 20 years ago. But I hope in 20 years' time it'll be a much richer story. So we still have a lot of work to do, and I hope some of the people in the room will contribute to that work. The other thing that while I've been here was, people sort of say, well, where are the people in South Africa who are interested in this kind of work? And I think there's not a visibility for this kind of work, but over the kind of seminars we've had between sort of 12 or so, or 13 people here now to about sort of 25, 35, and it certainly feels around Cape Town there is a nascent community, and I think people know each other and they already work together quite well, but there may be opportunities about saying, well, how do we actually sort of further accelerate sort of this is an area of research by starting to work in some sort of cross-institutional way. But I think there's, maybe if I was in Joburg, I'd again found this a similar situation, but it seems to be in Cape Town there's enough people who've both got some track record, I know are very interested in this, but also working in a province which seems to be quite innovative in many ways. And I think there is an opportunity to try and take this forward and develop the field. So that was it. I really enjoyed being down here and really enjoyed people's hospitality, and I'm glad that you've come to these seminars, so thank you very much. Any questions, or are we good? We can be good. Awesome.
I'm really glad you gave this talk, and I think it's an extension of what you were talking about in Paris 2 years ago. And the thing that I think keeps coming up when we're doing quality improvement research is people just say, oh, we want to just do something, and there's no place to go for a review of what has been happening in that area. And then people are like, but I'm too busy, I don't want to go through, all that research. And so we end up with a cookie cutter methodology. Oh, we learned it from so-and-so, so we just do our methodology in this way. There's no learning of methodology, and there's really no theory. And I think that's what this whole talk has been about. So I just hope that there's a way out of our situation. Because you guys, with your systematic reviews in your trials, it seems like you're moving somewhere. But with quality improvement, I don't know if we're in that spot yet of starting to think of it as a science and
Well, I think it's kind of interesting in the quality improvement field. I mean, originally when IHI was being set up, it's like we have to. It's too much of an urgent situation. We have to move on, and we've got these common sense things that we can build, import from other industry, and that we think will work. And sometimes they didn't, sometimes they didn't work. And I think it took a little while for people to start to recognise it didn't always work. And why didn't it work here versus there? Why did collaborative appear to work for heart failure but not HIV? And I think it's there's been a growing emergence of thought leaders in improvement science who are probably a bit frustrated that what they assumed would work hasn't always. And that they need to advance things. So, my frustration is that there's been if you talk about the pseudo innovation, we now have improvement science. It's sort of like, oh, for goodness sake, why call it something different? But we just need to find ways of building bridges and trying to work together. The issue is action without trying to learn from it. Could mean you're spinning your wheels. I had a colleague, Wendy Graham, who was putting in for Gates Foundation grant on maternal mortality, and she was reflecting on 10 years since there's a big WHO declaration about maternal health in the late late 19, or maybe in the 1990s. I want to say Bamako, but I could be completely wrong. I could just be the availability heuristic. And what she the comment she made was that when the declaration was made, people said it is too urgent that we have to. This maternal mortality is such a major priority that we just have to go and do things without evaluating them. And Wendy sort of reflected that unfortunately meant 10 years on, clearly other things had happened. HIV and TB had come through. There could be good reasons for this, but there was very little evidence that there'd been any major impact on maternal mortality. And so that's a kind of decade of lost progress. So we need to find the right balance between action and evaluation. And I think you can actually, often we can actually blend them better than people give credit for.
In our experience, my experience over the years, the times when you actually had to pick up from the policymakers, if you come with the evidence in hand, they really would never say, okay, we'll wait 3 years for you to do the trial. Never mind funding you to do the trial. But it's really quite a frustration, and the once or twice or 3 times in my career where one actually brought them results and they grabbed it and ran with it, like self-regulations, it's really, really scarce over our career of public health research.
Yeah.
So there is really that frustration. They want the information now. We haven't got the information now. And then there's, of course, always the expert opinion.
Yeah. There's a wonderful essay by Donald Campbell, the social evaluator who did Shadish Brook and Campbell, and the Campbell collaboration was named after, called the Experimenting Society. And what he sort of said in the essay was, people see me as an evidence wonk, which I am. But they then assume, because I'm an evidence wonk, that I think that we should not do anything until we have the evidence. And that's wrong. If we have the evidence, we should use it. If we don't have the evidence, we should experiment, we should innovate. But when we do that, we should be very cognizant of our lack of knowledge, and we should be trying to evaluate. And he talks about being an honest, experimenting society, and being willing to learn and say we were wrong. I mean, one of the problems in public policy is that normally, given the kind of public debate, policymakers have to demonstrate, you have to go out there and say, politicians, we're going to reduce maternal child HIV spread by this amount by doing this, to actually get it into on the public debate. Whereas actually there may be a lot more uncertainty about what would happen. But we end up sort of almost forcing our politicians into probably a level of certainty that they don't have. And then it's very hard for them to get out at the end and say, well, actually it didn't work. Because then, well, your program failed. Whereas if we could be much more honest and say, we think this is going to work, but we're not that sure, so maybe we'll evaluate it. And if it doesn't work, that's great because they'll learn something. And we'll move things forward. So I mean, the Campbell paper is just lovely. It's really, really worth reading. But I think also we need to sort of try and espouse a society where people can try things and say, we're wrong. And not for that to be seen as a negative, but it to be seen as actually great. You trying and failing is better than not trying. Anyway. Yes?
That series of sessions, which is from the beginning of this. I really enjoyed a lot of it. You learned me a lot. But what I'm trying to say is that I think it's quite challenging in terms of now we can know that implementation science is as a science, it's good the frameworks, the theory, the models, but the issue is how in different settings, different countries, different resources, how to implement and to integrate those moments actually, which is quite challenging. For example, in primary care level, whatever that level, and in which way we can, as you mentioned, cooperation, which is a very good method, but it's unlikely to take that concept from the regulation or policymakers and other people to engage. So I'm just thinking in the future how it's the working in which the more utilization and dissemination of that, creating that models, which is to somehow interfere and find a pathway to getting the code of quality service in healthcare sector. Gentlemen who comment some of that. Just thinking how it goes.
Yeah. So I think there's probably 2 or 3 responses. One is, undoubtedly, particularly if you're looking at, say, sub-Saharan African context matters usually. So one of the challenges is trying to understand whether the kind of models that have been developed to date can accommodate differences in context, or are they so different that we need to be different models? And when we had the Afro-Implement project, we brought down researchers from Europe to work with researchers from South Africa, Zimbabwe, Zambia and Tanzania. And what the researchers from Europe worked out was that for them, it was hugely intellectually rewarding because we were trying to work out how to ask questions without a knowledge of the context. Because if you work in a context, you often know how the system works. And we'd ask these questions. What about these sort of things? And Chriselle and Dick would look at this for a while, or Ferdinand from Tanzania would look at this for a while. And we were trying to find ways of trying to make some of these things, or understand what the fundamentals were in a way that was not context fixed. I think a lot of the models we're developing we're building upon generalizable theories of human behavior that probably are relatively robust to context, but different things will influence them. Okay, so theoretical domain framework I think would apply here, but it may be very different things. If you talked about barriers to hand washing in the rural Cape versus say Canada, I think the framework would work, but I think the things that come out would be very different. Okay, so I think that's kind of useful. But I think some of the things then would be with a few sort of honourable exceptions. If it's a nascent community in South Africa, how do you? The stuff I presented is building on a 25-year career. And I say, you should do multi-arm trials, you should do this, you should do that, and blah 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 blah. That's that's the kind of this is if you've been doing this for a long time, you might want to think about that. So I think if you're doing things here, it's entirely appropriate to be more to be slightly less ambitious in terms of let's just do the first trial and see what it's like, and get the learning from that, rather than thinking you have to build a super deluxe trial. But I think the other options would be, or the other issues are, how do we encourage linkages between experienced groups and less experienced groups wherever they are in the world, so there can be, I made horrendous mistakes in my first sort of, I say my first 3 trials, which were funded by the MLC in Welcome, there's the other one, maybe the Scottish office, were a learning set. I never said that to the funder, but they're a learning set, and we didn't recognise we were doing classic trials, a range of things like that. So I think there's an issue about how do we create linkages between experienced and less experienced groups to allow experienced groups to hopefully step over the kind of common mistakes and make more sophisticated mistakes. Some of the challenges for the experienced groups would be then, how do we engage in a way which is how do we engage in a way that isn't cookie cutter? That actually, so the thing in the Afro-Implement project that Martin and I talked about this quite a lot, which was quite striking for us, is we had to find a different way of thinking about things so that we could have a conversation that we think was useful for the partners who were down here. So you'd also want not sort of Jeremy coming in as a great expert and then rambling on, which is what I've been doing, and then leaving and just sort of assuming that this model that we use in Canada would work here. So I think we need to find a way in which we build bridges, and then those bridges will actually be mutual learning and a kind of respect that what works for me in Canada in terms of how I think about organising research may or may not, and it'll be adapted here. And so I think we need to find those kind of linkages. And it may be, there are a number, the NIH has a dissemination implementation seminar on a regular basis, and they will pay for people to get to that. You have to apply, it's competitive, you've got to sort of have a good idea, but last year colleagues from the UK and Australia got on, there may be ways to try to create linkages. So.
But can I just add one more thought? Always absolute pleasure for me to listen to you in the first instance. In the second instance, actually hearing your sensitivity of coming to this setting with African implement and now, of how one would do it here and make it work.
Mm.
So I suppose in a certain sense what I want to ask is it possible that you could also write and publish about the complexities of transferring models that work in the northern sophisticated hemisphere in developing country situations? Because I go back to after 1994, when the MRC opened up for the world, and we had weekly professors trained through our offices, which was very nice and good contact with the world. But you'd have those who walk in and say, now let us tell you what you should be doing. You serve them a friendly cup of tea and that was it. And then of course you had wonderful other people that would walk through again, very often from Scandinavia, who would say, well, okay, how can we work together? How can we help each other? And that's where collaboration is built. And because there was an incredible sensitivity for the complexity of transferring what's right up there in the Great North, and how you translate it to the resource scarce settings and complexities of it. And that conversation has hardly started. You know, it really is very, very challenging. And I suppose my plea to you is, don't let your excellent work of the last 10 years bypass addressing that incredibly complex question. I hope I'm not very arrogant in asking that.
No, but the issue is, I agree with what you're saying. It is something that we could have probably written something about around the time of Afro Implement. But this is the first time in, 15 years I've been down and spent any time down here. And I've not sort of engaged in that kind of level of discussion that we had there. So I don't think I would be the right person to write something like that. It does sound like you might be the right person to write something like that. No, because I think it's important. Because in Afro Implement, Martin and I thought about this quite a lot, because we realised that it was a huge learning experience for us, because we had to sort of try and break out of our context specific. I think it probably was one of the things that really helped our intellectual development. And there are other people. There are good people who come down regularly, who collaborate regularly. There may be other people who would be much better at presenting that. I'm just aware, I don't think it would be credible if I kind of said, well, we did some work in South Africa and Southern Africa 15 years ago. Then I kind of went to Canada, in the north, and got cold for 15 years. Then I came back for a couple of months and really didn't do very much because there was a sabbatical. And I'm going to write to sort of say how these things should work. But so I think some of the things are, I know that there are people who got, who this is, they live this. I don't, from both sides, and it would be much better if they were writing this rather than me. And I've got a list of 27,000 things I should be writing anyway.
But just carry that request with you wherever it might be suitable, because it's not being addressed very often. So I think simply because it's such a difficult question. In many respects.
Transatlantic transpiration.
Well, certainly, so you probably have to. I think, unfortunately, if I want to stereotype, I think the US is probably, it's not just US to South Africa; it's US to Canada. But I do think that a range of people could be asked to sort of make those sort of reflections, and it would be very interesting to do so, because when I was in Europe, it was easy to get down. You could commit time to do this. It feels a lot longer from Canada. There's not been the kind of funding mechanism, but to actually kind of do something that would require, I think, quite a substantial contribution of time, which is one of the things that I've struggled with the last. Sorry, I'm now rambling and making excuses. Okay, so thank you very much, and I'll be back in 2017, that's cool.
And art is change.
Oh, it's dying. Kind of, it's not funding it, so